So if you remember the genetic classification system, yeah, that we use, so we talked about movement impairment, when the joint is stiff, so we mobilize with a variety of techniques. We looked at some neuropathic conditions, progressive neuropathy, PNS. Now we're going to look at the category of non-specific lower back pain, but when it's a controlled impairment, yeah, so motor control. So motor control impairment could be impaired into flexion, could be into extension, could be multidirectional impairment. So we'll look at that direction. Now, what is the evidence for local muscle dysfunction, low back pain? So increased lumbar multifidus fat or lower muscle fat ratio is being reported in recurrent low back pain. But there was, again, very small or no correlation between MRI and lumbar multifidus fat, no lumbar size, and severity of lower back pain. So if you look at this patient, you know, it's got quite nice muscle, yeah, you can see that multifidus is very well developed. Compared to this patient, you can see here, this is facet joints, the spinous process, and you've got some fatty infiltration in lumbar multifidus. So it doesn't tell you that if a patient's got lumbar multifidus fat infiltration that would happen, could be opposite. Okay, so changes in muscle could be as a consequences, not the cause of it, or back pain. Okay. Now this study had 154 patients with non-specific chronic low back pain. So we had 12 sessions of stabilization exercise versus 12 sessions of placebo. They followed them up at 2, 6, and 12 months. And in terms of pain, if you look at that, even 12 months later, not much of a difference in terms of pain. So either you did stabilization exercise versus placebo sessions. Yeah, I think it might be due to lack of that against the classification system, and therefore the results are a bit diluted, and there was no significant effect. Now, other studies also found similar findings in terms of exercise with stabilization versus graded activity in patients with chronic non-specific low back pain. Because when the patient's got that chronic or non-specific low back pain, it's probably more than just about pathoanatomy. It's just more about the motor control. Also, we need to screen for the thoughts, understanding what's going on. You know, fear. Fear is a big factor for patients with that persistent low back pain, right? Because they're not sure what's going on. Some of them, they're scared to bend because someone told them not to bend, because if they bend, that symptom's going to be worse. So they become sort of kind of maladaptive in terms of their movement behavior. Okay? But also people who has lack of sleep, constant stress at home, at work. These are the factors that can amplify the pain experience, yeah? So remember that modulators of pain, and some of the modulators can be turned up a bit, yeah, in those patients. Now, I remember when we, like 15 years ago, we used to really much focus on the core stability, you know, activating transverse abdominis or multifidus. But we found that the outcomes were not that great in terms of the clinical improvement. And if you think about, if you already remember the study by Rob Laird, those 4 categories of patients, how they move, and some of them used only hip strategy, some of them used only lumbar strategy, some of them, they had core contractions, so really rigid. So you can imagine if you do that, if the patient's got lots of core contraction and you give them Pilates, more stabilization, more core contraction, that probably is not the best for patient, isn't it? Because that can increase that load through a lumbar spine, increase the load through the facet joints. You know, so I think for those patients, we might need to look at some relaxation strategies. How can they turn off the muscles? How can they relax the muscles? Not really all about core stability. I think core stability can be very good for people who have more low tone, or maybe those who are hypermobile or sway back, really kind of hinging on the joints, and they have no muscle support. So for those patients, probably core activations or functional retraining is important. So, and again, Peter Sullivan in a British Journal of Sport Medicine, he wrote an article that it's time to change how we manage non-specific chronic low back pain. And that's where, remember guys, the Oribo questionnaire is quite important. And if Oribo questionnaire is quite high, that seems to be associated with prolonged pain and disability. Now, if one of the score questionnaires on fear is high, give them additional questionnaire, fear avoidance belief questionnaire. If people are hypervigilant, really kind of catastrophization, got lots of catastrophization about the back pain, give them catastrophization scale. There is another scale for that. So we can measure in terms of how they think, what they feel, how they act. And therefore we can focus on maybe not only rehabilitation but education and really see what's going on. And some people maybe need to see psychologists. Not because we're going crazy, because mental health is just as important as physical health, isn't it? And mental health, I think is a bit of stigma, that you got mental health, but like a lot of people, or we've all been in situations when our nervous system is a bit under pressure, isn't it? So I think not only the physical health that we need to look after, but also mental health. So it's really bi-directional system. And again, so this was a study with Peter Sullivan and Thurston. So they looked at the classification-based cognitive functional therapy in patients with non-specific chronic low back pain. So it was a randomized controlled trial. And they found there was good efficacy in terms of applying this model on the patients with non-specific chronic low back pain, because they sort of using more functional approach. Patient experience, some of the movement strategies that might be helpful. They also challenge the patient beliefs in this model. So really they've got this abnormal beliefs, and this prolapse means that you cannot move, you need to protect. We need to challenge that for it, because we know motion is lotion. Movement important regardless if you got this prolapse or not. Okay? So therefore, this classification system looks at, in the background, look at the also assessment, symptoms, posture, active range of motion function. And then they classify the patients according to the motor control impairment. Has this patient got more flexion motor control impairment, or extension motor control impairment, or maybe passive extension, or maybe multidirectional? So the whole process of assessment is no different when people come with acute back pain. We're still going to go through the same thing: posture, active movements, combined movements if needed, sometimes maybe not, some functional test that provokes the pain. So I asked them, pick up the pen from the floor. So I want you to have a look how they're moving. You're looking at the pain behavior. So people who are fearful of bending, what they're going to do, they may grimace in the face, they may exhibit some kind of rigidity in the whole spine, they may not want to bend their back. They might just pick up the pen kind of with a straight back. So we want to see those pain behaviors as well with movement. Good. And then they retested this classification system again to look if this is reliable. And then Ken found that when the patient's got lumbar flexion, motor control impairment, or extension, we can classify that, and it's a reliable system to use in our clinical practice. So let's talk first about flexion pattern, motor control impairment. So just also to let you know, motor control, I don't know how you perceive that. Motor control is not only about the weakness. And Paul Hodges, Professor Paul Hodges from Queensland, so they found that when people are in pain, like I said, muscles behave differently between different individuals. Some muscles become overreactive, some muscles become underactive, or even you can have changes within the muscle between individuals. So the muscle behavior to pain, very variable. So we cannot say that every person with motor control, they will have weak muscles. It could be in fact really rigid muscles. So that's also, this is how the motor cortex produces, I suppose, response to the muscles, isn't it? From central nervous system. So motor control. So don't think it's only about weakness or instability. Because when I was in physio for motor control, everybody's unstable. or when instability, some kind of needs strengthening and that kind of thing. Motor control is just how it responds, the muscles to pain. So flexion pattern, so if you've got a patient with a flexion pattern, so they may have in a history flexion injury or repetitive strain. Patient may complain of pain during flexion of movement or sustained flexed positions. They may have loss of lordosis. So basically they spend too much time in flexion. And the brain does not recognize that, so doesn't know what's neutral, what's anterior tilt, what's posterior tilt. They tend to spend more time in flexion. Remember study on high school rowers or cyclists? They tend to spend more time in flexion. So they overload the spine in flexion and sensitize it, and then can cause pain. Now if you think also about the muscle activation, if you're in flexion, lumbar muscles are in more lengthened position. So if you're always in that way, the way you sit, the way you bend, probably you're going to have some weakness, isn't it? Especially in the inner range of lumbar extensors, because in a lengthened position you're always. So that's why they might even fatigue when you get into the neutral, lumbar neutral. They may stay for 5 seconds and then they, I can't do it anymore. It's either too much or maybe it becomes almost painful because we're not used to that position. It must allow lack of endurance. Okay. Also, when you ask them to do that anterior posterior pelvic to find the neutral, they cannot find it. They either overshoot in extension, overshoot in flexion, but that's from other sensory cortex. Remember about brain smudging? Doesn't have that information to give them a good self-perception in terms of movement and posture. And when you look at flexion with these patients, flexion is not going to be limited. It might be hypermobile, in fact. So it's not going to be limited. Usually they have no restriction in flexion. The spine preferentially moves into flexion over extension. So this is a flexion pattern, movement control impairment. Okay? Is that clear? Yeah? Okay. And then, depending, of course, what the patient complains of in terms of the functional capacity. If a patient got pain in sitting, we need to evaluate sitting and have a look, can we modify something, reduce the pain, like what we did day one. If they got pain with bending or squatting or lunging, picking things up, we need to examine that functional position as well. Look at modifications, remember? We can load them up, we change the lumbopelvic position, see how they feel. Inflection versus neutral, maybe versus extension. So this is the kind of category of patients we will look at that. Okay, and then we can look at some other more challenging positions depending what is needed. So if you can see this guy, for example, he's got end range of flexion. So he definitely doesn't have any limitation in flexion. He's got, in fact, end range flexion, the lumbar, loss of thoracic flexion. But his strategy is overload the lumbar, but lack of contributions from the hips. Because as you flex, you also should flex the hips. Also should flex the lumbar, so it should be fairly relaxed movement. Also, this might be his strategy because he got tight hamstrings as well. Okay. So you remember this guy as well. So if you look at this, when he goes forward, he certainly doesn't have any movement restriction. If anything, he's got maybe too much of movement. These people may have painful arc through, when you've got painful arc through the shoulder. This it can be lumbar flexion, painful arc. But I think when the people say, when I bend forward, I get pain, you know what's also the follow-up question is? Is it you get pain as you're bending down or from bending coming up? Because in their mind, they might think it's still flexion. But in fact, it's coming from flexion into extension. And some of you know what they do? They go this way, and then what they do, they lock the spine and come into that extension, and what, ouch. So they jam up in the lumbar spine. So that's why we look at that movement pattern. So, and also just be a bit more specific. I said, so is it as you're going down that causes you pain, or from there going up? So that could be completely different, yeah? But they think it's flexion, yeah? Okay. Yeah, so we can see this guy as well. So he's got end range of flexion in the lumbar, thoracic spine, but there is lack of contribution from the hips, maybe also due to possibility of the tight hamstrings as well. Yeah. Good. Now this guy again, you try to ask him to move in your anterior pelvic tilt and posterior, and you can see this guy sort of preferentially drops into that posterior pelvic tilt. Now people who in the office get back pain and they sit on the lower chairs, so you don't like, yeah, the hips at 90 degrees, but if there is a lower chair at 90 degrees, the hip's going to be more flexion. If the hip's more flexion, what happens to the lumbar spine? More posterior tilt. So for people who have pain and more flexion, you may ask them to sit on the higher chairs, or even maybe come a bit closer to the end of the chair, which promotes extension, promotes activation of extension. So just, you know, for some people, you know, might be just simple thing like that might help to reduce the back pain. Okay, and also some people as well, when you ask them to correct, what they do when you ask them to find a neutral, they maintain in that when they go into a pelvic tilt, they still maintain lower lumbar inflection, but they jam up in upper lumbar extension. And I think the guy who, what his name, so with a glute spasm. So I'm wondering if you're doing a bit of a jamming up in that mid-thoracic spine. You said some of the rotation activities when you do it, when you get pain in the thoracic spine. So these people can have upper lumbar or thoracic pain because they just lock themselves in. Rather than, you know, when you do rotation, when the spine is relaxed, they kind of just lock themselves in, retract their scapulas, and do this. That is much more, you're going to increase the tension in the thoracic, but also in the lumbar spine. So movement should be fairly relaxed, even playing golf or when you do some gym stuff as well. So because some of that, I know I've seen some of the gym guys, and the personal trainers tell them, you know, lock your shoulders back when you do things. And what happens is they train themselves to lock their scapula back. And so think about the muscles between the scapula, always hypertonic. Thoracic spine also loaded in end range. So they don't know how, in fact, to relax the scapula. They don't know how to relax the thoracic spine a bit. So just, again, listen what they say, because they can give you a lot of useful information. Now, other things we can look at, so we can the patient maintain lumbar neutral, and maybe then lift one leg at a time. So can they dissociate lumbar from the hip? Or as they lift the hip up, they drop in posterior tilt. So they got that lack of dissociation. Okay? Anyway, we'll do this assessment anyway, so we'll show you what. Now, the Swiss study looked at the spinal positional sense and trunk muscle activity during sitting and standing in non-specific chronic low back pain. And again, what they found that proper reception is impaired in people with sort of more persistent non-specific low back pain, so they don't know how to find a neutral, and they overshoot either in extension or flexion, have no idea in terms of that movement precision. So when we want to retrain motor control, initially, maybe should be low load exercise, but more repetitions to sharpen the motor cortex, isn't it? So we do repetition like ballet dancers, we need precision in movement. Or, you know, gymnasts, we need precision in executing that activity. So often we may need to do low load, more time to sharpen the motor cortex, okay, for these patients. And this is just some of the things that we do, keeping lumbar spine neutral, and then using the limb and see if they can maintain that lumbopelvic neutral. Okay, and then functional activities. And you know, so some people with flexion pattern, when they come from sitting to standing, they might be still place the spine in too much flexion because they're not utilizing the hips. So as you're coming from sitting to standing, you also need some hip flexion and pushing through the legs coming up. And a lot of people do sometimes a bit strange things how they get up on the chair. So we can observe that and maybe retrain or modify and see how it feels. Okay. Now, if they, sometimes in sitting, for example, if you get them to do anterior posterior tilt, it's difficult. Maybe you can do proper kneeling so the gravity can help them to go into that more anterior tilt or neutral. So sometimes how the brain understands the movement, again, it's individual. So maybe from sitting, maybe we need to change to proper kneeling or supine sometimes as well, yeah? So depending on the patient. And then end of it, we need to also look at the specific task. What's the problem? Playing golf, playing tennis, just walking, or could be anything, isn't it? So think about the end result as well. Where do they need to come back to? Okay. And this study, what they found that patients, this was 108 patients with non-specific lower back pain or chronic lower back pain, and 102 normal individuals. And then they applied different battery of tests in different positions. And when they found people with non-specific chronic lower back pain, they were more positive on more tests. So they failed the tests in different positions more commonly than control group or normal individuals without back pain. So because I suppose that somatosensory cortex is a bit impaired in those patients. Okay, good. So we talked about it now. So let's go and talk about extension patterns, movement, or motor control impairment. So extension pattern motor control impairment can be further subclassified in active extension and passive extension pattern. Active extension and passive extension pattern. Now, active extension, I think, to make it a bit more simple way of thinking, is this high tone patient, maybe hyperlordotic patients. Think about those gymnasts or ballet dancers. So hyperlordotic, loss of muscle tone. So they would be active extensors. Okay? And passive extensors is low tone, more sway back people, more the ones who just hinge on the joints. So they really overload the spine because there is no much muscle activity going on around the lumbopelvic region, or even, other parts of the body. So this is an example, isn't it? So this is more upright, more high tone, versus this guy just slumps, just kind of becomes low tone. So call him high tone or low tone. And that makes sense what to do in terms of rehabilitation. So what do you think? What's your gut feeling? For high tone, for loss of hyperactive muscles, what would you need to do? Perfect, yeah. And for low tone? Yeah, so you might put them, for example, we'll have a look at some ideas. But with people low tone, if you've got office job, put them on that football. A bit of a stable environment. Get their muscles to start activating a bit. So think about those different strategies, how you can increase that tone in the muscle or get them, and how reduce that load on the joints. Now, people with Ehlers-Danlos syndrome, you've got hypermobility syndrome, you can do Bateman scale. It's a Bateman score, so you look at the hypermobility, like at the elbows, at the fingers, at the little finger, and the knees. Sometimes where people do have different type of collagen, and it's genetic, and they seems to be a bit of a risk factor of developing musculoskeletal pain for those hypermobile patients. So for this, yes, control, Pilates, activation, perfect for these patients when they have this kind of low tone, yeah? And this is kind of, you can see that example, yeah? So definitely this patient is not low tone, huh? So he's got, in fact, a lot of increased muscle activity. This guy also sits in very upright postures. But upright posture, remember what I said, it can be driven from beliefs. Because maybe parents told you as you were little, sit up straight, sit up straight, sit up straight. You look, and so by sitting straight, you almost train yourself to do that. So it could be belief-based why they're sitting with one way or the other. And that can drive pain and muscle tone. So just kind of be mindful of that. Now we know people who are more down, a bit more depressed, commonly they sit more in slouch, slump postures. That also could be part of it, why they adopt those postures, yeah? Now, with active extension pattern, again, extension will not be limited. In fact, we're going to have very good range in extension, but might be painful. But also when you ask them to flex, they tend to maintain lumbar in extension. So this active extension pattern, yeah? So can you see that? So as I'm bending, I'm maintaining my lumbar in extension, so that's what we call that active extension. They don't know how to relax. They don't know how to soften and be like a monkey type of thing. So think about those patients in your clinic already. Probably you're thinking, that's my patient, or maybe that's patient, yeah? So these people could be again driven by fear sometimes, or maybe this is how they learn to move and now it's painful, or they just got so much strain in the muscles and that's going to increase that load faster than this. When you ask them to extend the hip, what they do, their primary movement drive in the lumbar. So lack of dissociation between the hip and the lumbar.
Lack of dissociation.
Lack of dissociation, yeah. So they preferentially move in the lumbar and not in the hip. They can't keep the lumbar neutral and extend the hip. Okay, so this is again the guy when you ask me extend, so it might be hinging at times, but especially if you look at the guy here, you know, the girl here as well, so she's got low tone, huh? So she's all like just hinges in that extension. Yeah. Even the guy, yeah? So just observe how they do, and typically with a sway back, remember when we look at the posture, greater trochanter will be posterior, acromion will be posterior to the greater trochanter. So they tend to then, what happens, overload that L5S1. They can jam up in that L5S1. And they say, you know, like the Kettans, if you someone said there is no difference in sitting posture between healthy controls and people with non-specific chronic low back pain until subclassified. And active extension pattern sits more in low doses and has difficulty changing the lumbar posture and slump. And it can be a problem. Now, if you've got a lot of low doses all the time, what happens to the hips? The hips are more flexion. Hips have more flexion, you might have tightness in iliopsoas muscle. Iliopsoas muscle attached to the lumbar spine. So sometimes when you ask them to go into that posterior tilt, they cannot do it because iliopsoas is not allowing them to go into that posterior tilt. So we need to do Thomas test, and if it's got some tightness, we might need to do some release through that hip flexors a bit. Or maybe activate the glutes so they lengthen through that anterior hip structures. And this is some of the examples, as you can see. Some people, when they ask them to extend the hip, they may preferentially also extend their lumbar spine more. And they don't know how to relax that lumbar spine. And then the right of resistance, again, we can test depending where the problem is. Is the pain with hip extension? Is the pain sitting to standing? Or maybe when they go into the gym and do 4-point kneeling exercises or whatever. So I just go by what the patient really. And I think you maybe got a bit more low doses, huh?
I have all the points of the active.
I know, exactly. So you are classical, I think, active extensor in a way. Yeah. And so for you, maybe you may need to learn how to soften through that lumbar muscles. Do you get back pain or not?
No, but I do a lot of core workouts.
A
I
lot
do
of-
a lot of core workouts, like a lot. So maybe it's just very, when you do just activation of the core every time. Like as you said, even if you want to like flex, I'll probably.
No, and I think that's right. So when you flex, and then you look at it, you flex more through the hips and lack in the lumbar flexion. But it might be okay for you, you know. So I'm not saying that everybody with low dose is going to have pain, but when the pain people come with pain, we want to work it out. What are the contributing factors to it? Is it because we're just not unable to relax? Is it because there's some disbalance between hip flexors and extensors? So we're just again assessing and building a picture. But I'm not saying that everybody with low dose we need to change that. We don't. But if they're in trouble, they come to see us. We kind of want to work it out why it is. And that's why, you know, we're coming to that iliopsoas, you know, we can do that. First we'll look at the hip tightness, if they've got any. Because if they do, so this test could be testing for hip flexors, or tensor fasciae latae, or rectus femoris. So if a patient on your Thomas test has a lot of abduction, maybe the ITB is tight. If a patient's knee is not relaxing at 90 degrees, maybe rectum is tight. Or if the hip is lifted and it's not touching the bed, hip flexor is tight. So you can even look at some of those things. And I think, yeah, sometimes you might need to do work, some soft tissue work to do, or you do dry needling or PNF, whatever you do, how you can dampen that muscle activity in the anterior hip structures. Okay. And then you can see here, so as the patient extends, so they seem to be all preferentially extending in the lumbar. It looks, oh, she's got a lot of hip flexion at the expense of the lumbar spine. Because hip flexion should be around 10 to 15 degrees, isn't it? Good. So other way maybe to reduce that, if you put the pillow of the towel, so get her out of that extension, maybe activate a bit of it more, and see if she can dissociate hip from the lumbar spine. Okay. So a variety of strategies that you could do for these patients. Okay. Now, which specific mode of exercise strength are most effective for treating low back pain? So it's sort of more recent systematic review. Like, again, depends what you read. If you read Pilates research, maybe they say Pilates is the best. If you read, other type of exercises, people who are very biased to strength, they say strength is the best. If you are yogi, maybe yoga said is the best. I think, look, there is no consensus, there is no gold standard. And I think it's good, because then we can be creative, but also we're looking what the patient needs. Because like I said, we cannot put everyone in the same group and give them the same exercises. Certainly some people will improve, some will get worse, and that's why the average is no difference. So then you think, okay, well, nothing is working in physiotherapy. Maybe I should change the profession. But I think also because sometimes it's hard to control some of the studies, but also how the design of the study can give you those kind of results as well. So do not get disappointed. But of course, I think we can really help a lot of patients anyway. This is case series. So we had 38 patients with non-specific chronic low back pain and control impairment. So treatment aim was to improve motor control. Average, we had 9 sessions. So they evaluated control, so the movement pattern, patient-specific functional scale, and disability. So in control, so with this approach, control improved in 59% of patients. Again, disability or patient-specific function could reduce 41, so that's good, and disability 43. So, depending what they need, I think if they got this motor control and you find which direction you do the exercise according to the patient's presentation, you can get fairly good results. But also, guys, I think, don't forget, when there is a chronic pain or persistent pain, you may have permanent changes in the brain. And even sometimes that's why medication not always works 100%. That's why the exercises still, people can have pain. So if they have this persistent pain, and I think we have a discussion with the patient, especially if it's a genetic profile, that primes them to more pain because they're choosing their own parents, so it's their fault anyway, or basically because it's been for too long, so the pain messages are just too ingrained. So then what I would suggest you to do, find what they are struggling and what is their goal, what they want to get back in doing, what is important for them. Maybe play with the grandchildren, doing something else, play basketball, whatever it might be. So then, less focus on the pain, more on function. Because the pain is still going to be in the background. So we might not get 0 out of 10 pain. It's impossible. Because they got maybe irritable bowel syndrome. They also get migraines, tension type headaches. So these are this genetic profile that is unfortunate that they are more likely to have pain anyway. But then work on function, and what they found that when you improve a function, you reduce disability, you improve confidence, what happens, you also reduce pain in some people. But not always 0. So we should not aim always for 0. because it's just, for a variety of reasons, may not be possible. So find that, I suppose, a clear relation with the patient and set the clear goals with them, and that they agree with that as well. So they agree with that goal. And then I think then don't promise that you're going to be paying free in 3 months. Probably not likely. But certainly you can get them stronger, more confident, so they can get back into doing things what's meaningful to them. So find what's meaningful to them, I think. And then don't ask with every movement, is it 2 out of 10 pain or 5 out of 10 pain? Is it relevant? Which way feels better? Worse, maybe don't use pain language as much, but then expose them gradually. Okay? Good, and this is kind of, I suppose, that was this study. 12 out of 21 patients with non-specific chronic low back pain. And the patients were suitable for motor control intervention. So they had 12 weeks intervention weekly for first 2 to 3 weeks. Then every 2-3 weeks. So they had cognitive functional motor control or manual therapy plus exercise. So they had significant improvement in pain and function, sick leave, anxiety, depression, and fear avoidance over 3 months and at 12 months. And 3 more patients satisfied at 3 months and five times more at 12 months. So the rehab for persistent pain patients is longer. So I think to see changes, you need at least 3 months of rehab. Not going to be just 2 weeks, because if you want biceps, you're not going to get biceps in 2 weeks going to the gym. So it's the same kind of the principle as well. And look, and that's why what we know, pain self-efficacy mediates effect. So meaning, like if self-efficacy is confident, so if patient is less confident, less trusting their back, more likely they're going to have more pain and disability. Give them more confidence, expose them, ask them to commit to rehabilitation, and then possibly that definitely will reduce disability, but not necessarily pain. Okay, it can be, but yeah. So this study compared, CFT, cognitive functional therapy, versus group exercise, for chronic low back pain. And it wasn't really a lot of difference between those two groups. But certainly people who gain more confidence, more exposed to things, they have less disability. Okay, and this is just another case study for flexion pattern impairment. So we need to think about cognitive factors. So if you've got fear, so really need to challenge fear, expose them to the fearful activities, to reduce that anxiety, to reduce fear. Look at the functional movement, lifestyle factors. So if people, like I said, sit 80% of the day, 10% standing, maybe 10% walking, so it's a lot of sitting, isn't it? And plus if the people are smokers and maybe drink a bit of alcohol or maybe more than what's recommended according to health organization, that can also add to that inflammatory suit. That can cause that low-grade inflammation due to the lifestyle factors. So cigarette smoking for sure, and also alcohol. So, and lack of sleep can also drive that, more pain, more sensitivity. So when people try, sometimes put on you, oh look, I don't think your treatment is not working, or maybe whatever you do, is probably not working. You know what to do? Be smart, put it back on them. In a nice way, of course. But if they have not changed their lifestyle, and this is a really dominant thing, very sedentary, eating not healthy stuff. I'm not talking about on the weekends, we all like a burger or whatever, that's fine. But if on a continuous basis, because that also food is inflammatory, can be pro-inflammatory. So you may be doing all the right things, but if people are not committing to change some of the lifestyle factors, then also you need to flag it in a nice way. I said, and I asked him, so can you tell me a bit about your lifestyle? What do you do day to day? So I open the question. I don't interrogate, how many cigarettes you smoke or how many alcohol you drink. So don't interrogate them, but sort of, can you tell me a bit more about your lifestyle? So what you do, what things you like, what's your day to day looking like? And see what they come up. oh well, I'm not doing much, you know, so then you can build that story. So you gather information, what the patient is telling you, and at the end you can summarize. So look, so what I'm saying, you know, from these things, what we know from the research also that smoking can be a bit pro-inflammatory, can cause a lot of other health, so it just as a health professional, it's all about wording, how you word that as well with some of the patients. Good, so guys, so we went through this, the whole info now, so now we're going to look at a bit of assessment, yeah? For the patient.